major suspect turns out to be air pollution, including diesel exhaust that trigger asthma and magnifies its problems. And of course, who causes pollution? We do. So that's what makes it a social problem. Why are U.S. campers coming down with Lyme disease? Researchers chalk this up to global warming. So here's how it works. There are more ticks because the warmer Earth provides them with a more hospitable environment for them to survive. With more ticks, more humans are bitten, leading to an increase in Lyme disease. So as the Earth heats up, it changes who can live in the environment for how long. Lastly, it says, how did COVID-19 become a thing? Although questions still remain, COVID-19 is also thought to have originated with bats, that from bats it went to mammals, or pangolins, and from there to humans. And then we know what happened when it came to the humans, we spread it from one human to another. To uncover the social causes of human diseases, medical researchers try to tease out connections, again, between human activities and that disease. So let's talk about social organization of medicine. And this is where we really start to get into what the social problem is. Medical costs have soared in the United States. In 1960, the nation's medical bill ran $28 billion. Today's cost has exploded to $4 trillion, about 150 times higher. Some of the causes include more elderly people in the population, new expensive medical technology, and the commodification of healthcare, or commodification means making money from it. C-section births are a form of surgery where a baby is cut through a woman's abdomen and uterus. This type of birth results in extra profits for doctors, causing many to prefer this method of birth, even though it carries greater risk for the mother. Cesarean births also cause longer hospital stays. So let's go back to that little opening story that I read from the beginning of the chapter. So they were telling the woman Kathy that she had to have a C-section because she had only dilated like 5 centimeters, right, within all those hours. But if you remember, they gave her medicine to help her dilate, and then they stopped the medicine. So they interfered in that natural cycle of childbirth and kind of told her, well, because of that, now we have to do a C-section. So it's like, you got paid, you're getting paid for this, now you're getting paid for the C-section. Now they're saying that causes her to stay a couple more days, so of course the hospital gets more money for that. So it can be really costly to have a baby nowadays. Quality of medical care is also preserved for those with good insurance or money to pay for services. So if you've ever had an experience with that, you probably know how that works, but personally that is the key for me. I really struggle with medical care when I don't have good insurance. Those with government insurance experience different quality of care. Again, the type of doctors you see, the services you have, the amount of time you wait, the cleanliness of the facility, all those things matter when it comes to medical care. So basically, when talking about social organization of medicine, it's basically looking at how, not the facility, what's the word? How the whole system works, right? It's just another area that there's some inequality if you can't afford the best insurance or the best care. So let's talk about medicine for profit. Medicine for profit is also known as a fee-for-service medical system. Under this system, physicians are like mechanics and plumbers. They collect a fee for every service they perform, right? It's not like, hey, you pay $500 and you get your car fixed. No, it's you need to get this battery, then you need to get this belt, then you need to get this insert. That's how it is with the medical system. They collect a fee for every service they perform. And like mechanics and plumbers, the more services you sell, the more money you make. In a fee-for-service system like this one, healthcare is a commodity to be sold, not necessarily a citizen's right. So again, if you have the money to afford all of those different things, good for you. But if you don't have the money to afford all those things, your health will suffer. Our fee-for-service system has led to what we call a two-tier system of medical care. The two-tier system of medical care consists of one for those who can afford good insurance and another one for those who cannot. Because our society treats healthcare as a commodity to be sold to the highest bidder, our medical care ranges from the finest in the world to subpar services. Again, it's all about what you can pay for, or what your insurance can pay for. Okay, let's talk about physical issues. 2 ways social researchers evaluate the general health of a society are to analyze life expectancy and infant mortality. In the U.S., life expectancy has been increasing for more than a century. Life expectancy is related to income, education, and race ethnicity. So we're going to watch a little video, and it's called Is Racism Toxic? So we're going to see the effects of that on our actual bodies. So it says, is racism literally toxic?
Imagine being at a fancy party. You're looking sharp with a hot date, having an amazing night. That is, until someone walks up to you and hands you their empty glass. They assume that because you're a person of color, you're a waiter. Awkward. Maybe you can laugh it off once, but what if it keeps happening? When you shop, security follows you around stores. You get pulled over by the police regularly. For many Black Americans, these experiences are common and can be much worse. A 2017 survey from Harvard found that 51% of Black Americans report personally experiencing racial slurs, and 52% report insensitive or offensive comments or negative assumptions. So, how do you respond to day after day of embarrassing, irritating, or downright terrifying interactions? That's gotta be bad for your health. Is racism literally toxic? Lately, scientists have been wondering if all that stress that comes along with just being a person of color is actually hazardous to a person's health. It has been well documented that Black Americans of all educational and socioeconomic levels live shorter, less healthy lives than their white peers. On average, 4 years shorter. Even more than just dying younger, Black and Native American people in particular have worse healthcare outcomes compared to white people. Research shows that compared to white Americans, Black Americans are more likely to die of heart disease, have a premature baby, and experience kidney failure. Infant mortality is far more common in Black and Native American families than white families. Another study found that overall, Black Americans and Native Americans fare worse in more than 20 different health outcome measures compared to white Americans. How is this happening? Is racism literally so toxic it can impact a person's health? To learn more, we spoke with Dr. Kamara Jones, who studies how racism impacts the health and well-being of the nation.
The most profound impacts of racism on health are in how they structure our educational opportunities, how they structure the neighborhoods in which we live, and even the environmental hazards that we find in those neighborhoods. So the bigger impacts of racism on health are how it's structuring opportunity.
And that's what we have to look at when we're talking about this issue. When we're talking about racism, we aren't just talking about your racist uncle at Thanksgiving. We're talking about institutional racism, also known as structural racism, a form of racial discrimination upheld by the policies and practices of social, political, and economic institutions. And that discrimination affects a person's health.
Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources.
How can some people be advantaged by other people's disadvantages? Dr. Mary Bassett, Commissioner of the New York City Department of Health, is an expert on community health.
It's very common for people to reduce these differences to personal deficiencies. They shouldn't smoke, they should exercise more, they should eat healthier food, they shouldn't drink so much. So reducing this problem to a problem of individual lack of discipline or lack of information really neglects the fact that people face circumstances which make it very difficult for them to act on health advice.
Just really quick, what she's saying there is kind of what popped into my head was when we talk about personal problems and social problems, right? So I don't know if you guys remember like the very first class, we watched this video about obesity and how like what part of that is a personal problem and what part of that is a social problem. So how she was saying, we say to people like, oh, you should stop smoking, you should eat healthier. Obviously, those are personal problems, right? If I'm talking to a healthcare about like wanting to lose weight, they may tell me like, watch what you eat, exercise. It's a personal problem. But this woman is talking about those social aspects like the environment, things that we're going to get to in a couple weeks, and how those are affecting the health of people as a group. Like for instance, the Native Americans and African American communities that she's talking about. So I kind of just wanted to connect that to what she was saying because it made me think of that week one.
Maybe the neighborhood doesn't have sidewalks for taking walks, or maybe they work 2 jobs to pay rent and don't have time to exercise. But other people of color might live around the corner from a Whole Foods and have a fancy gym membership. But that doesn't mean they're off the hook. Remember, data shows worse health for minorities across income and educational levels. After all, it doesn't matter if you're rich or poor when you're getting pulled over or being eyed suspiciously by a store clerk. Are you still confused about how discriminatory institutions can impact health? Maybe this will help. Another prominent group of Americans has experienced a drop in life expectancy recently. That group? Lower middle class white guys. White guys. Middle-aged white men without a college degree have been afflicted by what experts have dubbed deaths of despair. Drug use, alcoholism, and suicide. As you can see, the past 15 years have been pretty grim. And society jumped on this alarming public health crisis. Get these people into treatment. They need help. That's a perfectly reasonable approach. But it's not one that has been applied equally to other communities facing the same issues.
The level of empathy that we've seen around opioids in this round of the epidemic has all to do with who is being trapped by drug dependence. It's not the way that our society responded when the majority of people who were getting trapped by opioid dependence were people of color. Then it was failed families, failed communities, and the war on drugs.
When a public health crisis comes up, how urgently society responds largely depends on the identity of those people affected. Just look at the AIDS crisis, or the crack cocaine epidemic of the 1980s and 90s. Both of those affected marginalized populations, and institutions that could help were slow to respond. We're talking about addressing an issue with deep roots. There are no easy answers. What can we do?
Part of our challenge is to get the conversation going. These are often uncomfortable conversations, but the way to tackle it is to have conversations about racism and health in our country. If we don't see it, we won't change it.
Work to see the systems of power all around us, whether they privilege or oppress you. If this video made you uncomfortable or presented you with new ideas about how our society works, then good. We've already started.
Okay. So that was just a little bit showing us how everything is kind of connected and things like life expectancy, infant mortality, and even lifestyle are affected by outside sources like where you live, your financial situation. Like she said, maybe you have 2 jobs and you can't necessarily take that extra time away to go exercise like somebody who has 1 job type of thing. All right. So a primary reason why life expectancy has increased is the decline in the infant mortality rate, the number of babies who die before the first birthday per 1,000 live births. The infant mortality rate reflects the quality of nutrition, the health of mothers and babies, and the quality of health care. So as we know, way back in the day, a long time ago, when we didn't have all these fancy medical technologies and facilities, we obviously had a higher infant mortality rate, but now that we have all of these advancements in technology and stuff, we as a nation have a higher life expectancy and a lower infant mortality rate. Lifestyle is a major cause of illness and death. To mention the most obvious, overeating and lack of exercise leads to heart attacks and strokes. Smoking causes cancer, and the abuse of alcohol harms essential body organs. These are all a part of the social nature of physical illness, right? Because these are the things that we are choosing to do that affect our health. At the core of the social problem of medical care lies this contradiction. We live in an age of chronic illnesses, right? Lingering and ongoing medical problems people have going on, while our medical services are geared for acute illnesses, those that have a sudden onset, a sharp rise, and a short duration, so things like the common cold. Our medical approach to cancer, heart disease, and other chronic disorders is heroic, hospital-based, and expensive. And what I mean by heroic is, think about it. If you have cancer, heart disease, or a chronic disorder, you already have it, right? And we're heroically trying to save you from dying from that. But the damage is already done, right? That's the difference between heroic care and preventative care. Preventative care is things like going to the doctor and then saying, hey, stop smoking before you develop that lung cancer. So I don't really know why they use that term heroic. I think it's kind of dramatic, but that's what heroic means. Is like, I don't want to be dramatic and say like the end is near and now we're trying to save you from it. But that's what that like kind of dramatic term heroic refers to. So our medical approach to cancer, heart disease, and other chronic conditions is heroic, hospital-based, and expensive. Intervening after a disease is advanced requires highly trained specialists, technical equipment, and expensive drugs. Patients who have serious illness want the best care, and the medical world has taught us that the best means complex, expensive, and technical. Unlike heroic medicine, preventative medicine is not dramatic. Preventative medicine consists of quiet, behind-the-scenes activities, such as encouraging changes in people's behavior by promoting exercise, healthy eating, and reducing harmful smoking and drug use. Another problem with the medical delivery system is an uneven distribution of doctors. Some areas have an abundance of physicians, while others have few doctors. It's difficult for small towns, which offer few cultural attractions, to attract doctors, while large cities near major hospitals have doctors in abundance. Take Barstow for an example. Everybody in Barstow comes here to the Victorville, Apple Valley, Hesperian area because we don't have a lot of doctors. What doctor really could you entice to live in Barstow? I probably wouldn't want to live there if I was a doctor. So that's just one example of, like they go where the money is, where they want to live, things like that. So you do get an uneven distribution of doctors depending on different areas. Now let's move along and talk a little bit about mental illness. Mental illnesses are health conditions involving changes in emotion, thinking, behavior, or a combination of these. You are familiar with the high stress that people experience today. And you may know that our social support systems, like our family, friends, and community, have become weaker. Overall, it's impossible to know if mental illness is more common today or not. It could just be that we're talking about it. But there is also a two-tier system of mental health delivery, just like with the medical system. Like the two-tier system of medicine for profit, the mental health delivery system is also two-tiered. let's read about an example on page 300 of the text. So I'll go ahead. Here we go. So, and this is from the actual author. He said, I watched as an elderly nude man, looking confused, struggled to put on his clothing. With his bare hands, the man had ripped the wires out of the homeless shelter's electrical box, and then, with the police in pursuit, had run from one darkened room to another. I asked the officers to where they would take the man, and they replied, the state hospital. When I commented, oh, I guess he'll be there for a while, an officer replied, probably just a day or two. We picked him up last week when he was crawling under cars at a traffic light, and they let him out 2 days later. The police explained that only people who are a danger to others or themselves are admitted as long-term psychiatric patients. Visualizing this old man crawling under cars in traffic and risking electrocution by ripping out electrical wires with his bare hands, I marvel at the definition of danger the psychiatrist must be using. Here in front of me, the two-tiered medical system was stripped of its coverings. A middle-class or wealthy person would have received different treatment. Of course, such a person would not have been in a shelter for the homeless in the first place. So I guess the point of that story is, they're saying, unless he's a risk to himself or others, like, we don't keep him for more than 2 days. But the author is saying, you're almost electrocuting yourself and going into oncoming traffic. Like, how is that not, being a danger to yourself? But that's an example of the two-tier system of mental health delivery. So as you can see, the medical delivery system is also a part of the problem. It favors those with good insurance or those who can pay. People with more money are likely to receive individual counseling. People with little to no money are either ignored or given some form of medication. So let's talk a little bit about the social nature of mental illness. So what exactly is mental illness? This question lands us in the midst of a controversy. In the extremes, some psychiatrists see mental illness behind every shadow, while others still to this day will deny that mental health even exists, or mental illness, I should say, even exists. Whatever it is, mental illness has a strong social basis. That is, people who experience more stress are more likely to also experience what are known as mental problems. Mental problems are assumed to be the primary reason for suicide, although the matter is not that simple. Rates in each country usually stay about the same, but severe social change can create intense uncertainty, leading to an increase in rates, such as the 2008 recession. Another example, and I don't have data on this, but another example of something that happened that affected us all in our mental health socially was also COVID-19. So that led to, just different people having different experiences with their mental health during that time, depending on their support and what they had going on. There's also a difference in genders. Men tend to die by suicide at higher rates than women, yet women attempt suicide more than men. Women are also more likely to take pills, where men are more likely to use guns. So there is a lot of social influence on mental health. Now let's look at theoretical perspectives. So with symbolic interactionism, we know that they focus on defining meaning and how meaning influences behavior. We determine what feelings mean by using definitions that our culture provides. You will interpret your experience differently than will somebody from a different background. Let's take back pain for an example. People from lower social classes are likely to regard back pain as a part of life, something that they live with. People from the middle class, in contrast, are more likely to view back pain as a health problem that needs to be treated by a doctor, right? Maybe going to the chiropractor, going to physical therapy, things like that. You could almost say that it's a privilege, right? Like, some people have the luxury of treating their back pain, while others are like, hey, this is just a part of life, this is just what happens. Just as social classes and subcultural groups perceive illnesses differently, groups also compete to get their views of health accepted. What happened, health drunkenness, for example, was labeled as a disease of alcoholism. So again, people see sicknesses and illnesses differently depending on their upbringing, their culture, and just their own personal thoughts. Patients use what's called a lay referral network, people like family, friends, neighbors, coworkers, with whom they talk about their medical problems with. This network helps the individual decide what doctor to see, and the perception of a physician's knowledge and personality is important. So for example, you may tell your friend or your coworker, like, oh, I have this mole, and you know, it's starting to bother me, and you're talking with them, and they may say, you should go get that checked out. That's what they mean by different network of people that influence your health decisions. Or maybe you have a pain and you're like, oh, it's fine, it'll go away. And you have somebody say, no, go check that out, things like that. So when we go to see a doctor, their knowledge and personality is important. So is the confidence that they exhibit. Doctors who show uncertainty create doubt, even fear, while those who appear confident instill trust. So I guess we could all say we want the best of the best, right? We want a doctor that knows what they're doing and things like that. Patients also want to be sure that they get a shot or a prescription, not just advice to go on a diet or get more rest, right? The worst thing is waiting 10 hours in the emergency room for them to tell you, here's ibuprofen. Patients expect something more professional, which translates into medicine that only a doctor can give. So that reminds me of, like, I used to get these really bad headaches, and I would usually just deal with them at home. But there were a couple times that they were so bad that I went to the emergency room. So one time they gave me this shot, and I don't remember what it was, but it just relaxed me, and like, it was worth it, right? Then the next time they gave me an ibuprofen, and I was like, I have ibuprofen at home, and took it, it didn't help. So I kind of was laughing when I was reading that the first time, because it makes sense. You don't want to go to the doctor and wait all that time just for them to tell you, like, you need to get rest, or you need to drink water, or whatever it is. It's basically take care of yourself. Okay, so anyways, back with symbolic interactions. Lastly, there is depersonalization, where a person is treated as an inanimate object. And we see this a lot, especially in media portrayals of hospitalizations and doctors and stuff. So depersonalization is common in hospitals, where you hear things like the patient in room 303, or go check the cardiac case in 1707, right? They're not necessarily people, they're referred to as what it is that they have wrong with them. With the constant transition of patients, nurses don't always get to know individuals who are transformed into transitionatory medical conditions in specific locations. So that's another way we experience mental health care, or not mental health care, excuse me, healthcare, as being cold, dehumanizing, sometimes impersonal. Again, your experience depends on where you're at. You may have a doctor that you go see all the time, and they know you, they know your health history, and they know what's wrong with you. Or you have other experiences, like I have a lot of experiences like this, where you go to the doctor, and every single time you have to kind of retell your whole story. You know what I mean? So again, the quality of care really just depends on where you're at. Where you're at financially, physically, all that stuff. Functionalism. Functionalists assume that customs or social institutions persist because they fulfill social needs. So obviously these medical facilities do serve and fulfill a need of society. This perspective raises interesting questions. Whose needs are met by a healthcare system that is hospital-based and oriented towards acute illnesses? What are the benefits of depersonalizing patients or of making childbirth a medical procedure? Fee-for-service means profit. It is difficult for doctors to make money from people who are healthy, right? So that's like a key component for understanding this. It's hard to make money from people who are healthy. Sick people mean patients for doctors, and patients mean money. On On top of this, patients who get well quickly bring less profit. But a high profit producing hospital-based system oriented toward acute illness, that's a dream come true. Everyone, doctors, nurses, hospitals, medical suppliers, and drug companies all make money from patients who are given intensive care. Each year, about 35 million patients are admitted to a hospital and stay an average of 5 days. Functionalists believe that the problematic fee-for-service system is self-correcting. For example, although the medical system is oriented towards acute illnesses, after environmental health problems were recognized as serious, the government took a huge step toward preventative medicine by passing anti-pollution laws and establishing the Environmental Protection Agency. Medical schools also have responded, adding more training in environmental medicine. So essentially, this is saying that the medical system is a self-correcting machine. If something goes wrong, we'll do something to address it and fix it. Because remember, functionalism sees society or sees a system as a machine. So if a part of the machine breaks, we simply fix it. Functionalists also analyze functions and dysfunctions of medicine on a global level. So let's use this as an example. If we take Western medicine to least industrialized nations, so for instance, like some parts of Southeast Asia or Africa, this is a good example because we give them vaccines and medicines, and they reduce death rates, right? So that's a positive. But they're also dysfunctional because we now set the conditions for a global population expansion that worries so many. So on one hand, here's this medicine, right? We're solving these issues you guys have so you won't die or you'll live longer. But then on the other hand of that, okay, now they're living longer and now we're procreating, creating more people, and the cycle goes on and on. So there's pros and cons depending which way you look at it. And lastly, good old conflict theory. Conflict, sociologists disagree with the functionalist view. They argue the opposite, that the U.S. medical system is not self-correcting. Conflict sociologists view patterns of illness and healthcare in the United States as the outcome of clashes between groups. They argue that the poor are sicker than others because they have lost the competition for high-quality education, food, housing, jobs, and medical care, right? Conflict theory always goes back to those resources and people fighting over them. So who's going to have more access to all that stuff, the wealthy or the poor, right? Some will say, what about Medicaid, which benefits the poor? Conflict theorists point out that this program developed in conflict. In the 1960s, politicians were forced to take action regarding treatment of the poor. Congress saw Medicaid for the poor as the answer. However, the physicians' union viewed Medicaid as a first step to socialized medicine and feared that Medicaid was an attack on its profitable fee-for-service system. So that's why the fee-for-service systems don't like the programs that help them. Caught between these two interests, Congress designed Medicaid to satisfy both. More medical coverage for the poor, but also retaining the doctor's profitable fee-for-service system. In a capitalist system of production for profit, the relation of physician and patient is like that of owner and worker. Conflict is built into the relationship for the interest of one, making a profit from the illness, as opposed to the other, getting well at the least expense. Some doctors are surprised and even dismayed when their patients know more about a new treatment or some research. Each year, about 600,000 American women have hysterectomies, the surgical removal of the uterus and ovaries. This surgery is so common that by the age of 60, more than 1/3 of all women in America have had this surgery. But 1 in 5 of these surgeries is unnecessary. In some cases, the tests that indicate the need for the hysterectomy are inadequate. These tests might indicate the presence of a cancer or some other disease, but post-surgical tests indicate otherwise. In other cases, the doctors are unsure of the medical conditions and they remove the uterus as a safe precaution. In other cases, the dollar signs in the surgeon's eyes are the deciding factor to operate. So you'll see that a lot, right? Like, you don't have cancer, but in order to prevent the cancer, let's just take it out. just take it out so you don't have it. Which makes sense, but at the same time, kind of extreme to like remove parts of your body. Just like, let me remove my finger so I don't get finger cancer. I could see if you have like a high history of that in your family, that would maybe make sense, but that's just an example of the conflict. The conflict theory is just seeing the different interests, and money is always a part of that. So let's look at research and policy. Okay. Sociologists do a lot of research on health problems in the medical system. The top 10 killers in terms of death include pneumonia, tuberculosis, heart disease, and accidents, to name a few. These are different from the top 10 killers of the 1900s. The changes over this time make the social nature of death evident. Causes of death are related to lifestyle and environmental pollution. I think we go over environmental pollution in like 2 weeks or so, maybe 3 weeks. The same applies to infectious diseases. Those of the 1900s are not as big of a threat today with modern day vaccines and treatments. We have cleaner public water supplies, better living conditions, and improved overall health that contribute to the decline in infectious diseases. With the combination of antiretroviral drugs and education about unprotected sex, worldwide deaths from AIDS has also dropped, as well as transmissions from sexually transmitted diseases. Social factors largely determine who will be healthy and who will be sick, and this also translates to physical fitness. Poor children are more likely to be undernourished or to lack a balanced diet. In general, the poorer people are, the sicker they are. Even their death rates are higher. Remember, like we were looking at the video, they live less. People of color tend to live longer than whites. People's emotional well-being also gets worse the lower they are on the social class ladder. Those in the lower social classes are more likely to be depressed, anxious, nervous, and fearful. And there's two theories that address this. There's the drift hypothesis, and it's based on the idea that people with emotional difficulties tend to be less successful in life. People from higher income families who have mental problems tend to drift downwards, landing in the lower social classes. Then there's the environmental hypothesis, and that environmental hypothesis regards these differences in emotions as the product of different environments. Lastly, social policy, or almost lastly. Policies range from reducing the cost of medical care, then they look at preventative medicine and humanizing healthcare. To reduce the cost of providing healthcare for their workers, some employers buy prepaid or managed care. The best known type is the Health Maintenance Organization, or an HMO. A business pays a set fee to a medical corporation, or the HMO, which covers the health needs of the company's employees. If the health care of these employees costs less than the fee, then the HMO makes money. But if it costs more, then the HMO loses money. Another attempt to reduce costs is to give workers rebates for staying healthy, or at least from staying away from the doctors. In return for accepting a high annual insurance deductible, employees who spend less than the deductible are paid the difference between it and their insurance claims. So if the deductible is, say, $1,500 and workers only claim $100 for medical care, then they'll collect a nice $1,400 bonus. Another strategy for controlling costs is to use lower paid physician assistants and nurse practitioners who work under the supervision of physicians. Half to 3/4 of all the problems dealt with in a typical doctor's office are aches, sniffles, and other trivial matters. Physician assistants and nurse practitioners also manage routine tasks like giving school physicals and educating patients who have chronic disorders. That reminds me, I was with this doctor for about 4 years, and I actually never saw the doctor. I always met with the nurse practitioner, which was fine because, like the book said, I was only going for things like, flu and things like that anyway. But just an example. Okay, so another thing is training physicians. There are about 80 million more Americans today than 30 years ago, yet our medical schools only graduate about 3,500 physicians a year more now than they did back then. So